Hi, we're with Middle Georgia State College, and we're going to present an HESI case study. This patient is not a real patient, so therefore we are not in any violation of HIPAA. I'm Sara Land.
And I'm Angelique Lestagez.
And we have two assistants with us today that will be helping us point out our main topics.
I'm Haley Lynn. And I'm Bryce Wood.
Okay then. So, with this nurse, we're going to split this off into two portions, pre-op and post-op. So, you're a nurse on a med-surg floor that works with pre- and post-op patients. Today, you're taking care of Mr. Gold. You performed an H&P and this is what you found. Mr. Gold is 60 years old. He's 5 foot 8 inches and weighs 225 pounds. Recently, he's lost 11 pounds and has had a sudden onset of constipation and has been nauseous for the last 2 weeks. He has no known drug allergies, is not on any medication, and does not smoke or exercise. Mr. Gold's diet is high in fat and high in calories. His father has also died of colon cancer at the age of 58. The reason why he sought medical attention was due to blood in his stool. His PCP recommended that he get a colonoscopy. A large cancerous growth was detected during his annual colonoscopy, and it was determined that he must have an open colon resection / partial colectomy with anastomosis, as opposed to a closed or laparoscopic surgery. Besides bleeding, growths in the colon may cause partial or complete large bowel obstruction. Symptoms of large bowel obstruction may also cause a person to go to the doctor and subsequently be diagnosed with colon cancer. Two major symptoms of bowel obstruction are abdominal pain and distension.
All right. Risks for colon cancer are obesity due to high calorie or a high fat diet, increased age, history of colorectal cancer or bowel disease, lack of exercise, family history of colon cancer, type 2 diabetes, heavy alcohol use, history of smoking, and being African American.
That's mean.
Oh, honey, that's not mean. It's just some genes have a predisposition to certain diseases.
Mr. Gold is at increased risk for colorectal cancer for a number of reasons. First, he is obese with a BMI of 34.2. He has a high-fat, high-calorie diet. He has family history of colon cancer. He does not exercise, and he is over 50 years of age. He also admitted to rarely seeking health care, even though he had family history as a major risk factor.
Thank you, Sarah. Colorectal cancer is an early detectable cancer. Screening tests for colorectal cancer are available. These tests can be successful in detecting colorectal cancer in an early stage when it is most curable. Types of screening tests, frequency of screening tests, and age at which screening should begin all depend on an individual's degree of risk for colorectal cancer. More frequent screening is required for persons with greatest risk. For persons at average risk for colon cancer, guidelines recommend screening beginning at age 50. Yearly fecal occult blood testing is recommended for this risk group. Sigmoidoscopy every 5 years or a colonoscopy every 10 years is also recommended. With sigmoidoscopy, the sigmoid colon and rectum are examined. With colonoscopy, the entire colon and rectum are examined. A digital rectal exam, or DRE, may also be done to screen for colorectal cancer. By inserting a lubricated gloved finger in the rectum, the examiner can palpate abnormal masses in the lower section of the rectum.
During the preoperative period, you taught Mr. Gold about the bowel prep that will be required for surgery. Bowel prep is done before a colon resection to cleanse the bowel. Although protocols vary, bowel preps often include a clear liquid diet for 1 to 2 days, followed by the intake of an oral bowel purging solution, taken over a number of hours the day before surgery. Bowel prep for a colon resection may also include oral antibiotics such as erythromycin or neomycin that are taken the day before surgery in order to decrease the amount of bacteria in the intestines.
Now we're on to post-operative nursing care. Mr. Gold ends up having a partial colectomy, a segmental colon resection with anastomosis done under general anesthesia. He has just arrived from the PACU, and you have received report from the PACU nurse. Post-operative orders are noted.
These are your findings during post-operative assessment. Mr. Gold has an NG tube. Not all patients have an NG tube after a colon resection. Some surgeons choose not to insert an NG tube because the tube may promote gastric acid secretion and increase post-operative nausea. You check Mr. Gold's vital signs. He's got a BP of 124/80. His pulse is 76. Respirations are at 20 and his temperature is at 98.2 degrees Fahrenheit. Readings are consistent with earlier readings in the PACU. Mr. Gold's abdominal dressing is dry and intact with no drainage present. His IV is infusing as ordered, and the IV site dressing is clean and dry. The PCA is also infusing as prescribed. SCDs are in use on Mr. Gold's legs, and Mr. Gold is alert and he talks to you. He is not experiencing any pain. His skin color is pale pink. He asks for the urinal and is able to void 400 milliliters of clear yellow urine.
When in bed, the semi-fallows position, which is 30 to 45 degrees, should be comfortable for Mr. Gold and will facilitate breathing by allowing for downward movement of the diaphragm and full lung inflation. To help with deep breathing, Mr. Gold will be using an incentive spirometer. The aim with an incentive spirometer is to expand lung volume to total capacity to ensure ventilation of all alveoli in the lungs so the patient can take a deep breath. The spirometer portion of the device measures and reflects how deep the patient has breathed in. You will encourage use of the incentive spirometer every 1 to 2 hours.
Splinting of the incision, either manually or with pillows, especially when movement, coughing, or sneezing occurs, provides physical support for the healing wound, and it helps prevent dehiscence. Use of splinting should help Mr. Gold feel more comfortable with deep breathing and coughing. Mr. Gold has a PCA. You advise him to self-administer morphine before deep breathing and coughing, since this can be uncomfortable for the patient who has just had abdominal surgery. Taking a dose of pain medication before an uncomfortable procedure can increase the patient's willingness to carry out the procedure. The action of the IV morphine peaks at 20 minutes. Mr. Gold can self-administer a dose of morphine 20 minutes before deep breathing and coughing.
Mr. Gold gets out of bed and ambulates the evening of surgery. Early ambulation reduces risk for complications associated with abdominal surgery and general anesthesia, including hypoventilation, atelectasis, and DVTs, and constipation due to lack of peristalsis. In order to assess for the return of peristalsis, you ask Mr. Gold if he has been able to pass gas or have a bowel movement. You also take Mr. Gold's breath sounds. Breath sounds are diminished and crackles are noted on the right side. These are signs of atelectasis. Post-operative atelectasis can cause fever in the post-op period. You encourage Mr. Gold to perform deep breathing with incentive spirometer. The physician orders acetaminophen 600 milligrams rectal suppository every 3 hours as needed for temperature above 101 degrees Fahrenheit, since he is still NPO. You immediately administer the acetaminophen to Mr. Gold.
The physician removes Mr. Gold's dressing and he examines his incision. It is well approximated with staples and minimal redness, as expected the day after surgery. No drainage is present, although the possibility of a wound infection cannot be ruled out. Abdominal incisions are prone to dehiscence and evisceration. Dehiscence is the superficial separation of wound edges, and evisceration is when healing does not occur internally, and internal organs protrude through a disrupted incision line. The abdominal area commonly includes an excess of adipose tissue, which has a poor blood supply. Also, excessive pressure may be placed on abdominal incisions when post-operative deep breathing and coughing occurs. Evisceration may be preceded by excessive draining for an incision approximately 48 hours before disruption of the incision. It is important that nurses observe for these early indications of evisceration. In the event that dehiscence with evisceration occurs, apply sterile gauze soaked with sterile normal saline to any abdominal organs and the incision. This should prevent drying and possibly necrosis of the organs.
Mr. Gold's chest x-ray reveals atelectasis at the right base. Aggressive chest PT is ordered for Mr. Gold. During the evening and night shifts, Mr. Gold uses his incentive spirometer every hour. In addition, he is encouraged to cough after deep breathing, occasionally coughing up thick white mucus. A sputum specimen is obtained and sent to the lab for culture and sensitivity. The following day, Mr. Gold's temperature is 100 degrees Fahrenheit. His breath sounds are clear with good aeration at both lung bases. Crackles are no longer present. Occasionally, mucus is expectorated with coughing. By his third post-op day, Mr. Gold is ambulating 3 times a day. He is passing gas, which indicates the return of peristalsis. His NG tube is removed. Fluids by mouth are started and well tolerated. Mr. Gold's sputum culture was negative. His early post-op fever was probably a result of atelectasis, which was corrected with aggressive chest PT before pneumonia developed. Mr. Gold's condition continues to improve. He is discharged 5 days after surgery.
Mr. Gold's cancer was limited to the tumor in the mucosal layer of the sigmoid colon. There was no evidence of lymph node involvement or
metastasis.
Because Mr. Gold's tumor did not penetrate the bowel wall, he will not need chemotherapy. However, vigilant surveillance to detect new growths will be important. At present, colonoscopy is planned in 1 year. 6 weeks after surgery, Mr. Gold's serum CEA, which is carcinoembryonic antigen level, was normal. Although not a specific test for colorectal cancer, CEA may be elevated with a variety of malignant or benign diseases, including colorectal cancer. Before surgery, Mr. Gold's CEA was elevated. Now it's normal, which is a good indication that the cancer was completely removed. Mr. Gold's CEA will be monitored for elevation periodically because of an elevation could indicate the return of a bowel cancer or
metastasis.
Make sure that you know your risk factors for colon cancer as well as early detection of colon cancer.
So get checked.
Okay.
Now we're going to go over a few questions.
Okay, Sarah. Number 1. Which of the following interventions are important to include in your plan of care for Mr. Gold? Select all that apply. There's only 2 correct answers. Okay. First, assist with deep breathing and coughing. Check vital signs every 8 hours. Encourage the supine position in bed, or offer small sips of water as needed to relieve thirst. And lastly, encourage frequent change of position in bed.
Let me think about that for a moment. I think the answers, Angelique, would be assist with deep breathing and coughing. And the reason for that answer is to avoid accumulation of respiratory secretions that will decrease the risk of postoperative atelectasis and pneumonia. The second correct answer, Angelique, is encourage frequent change of position in bed. This reduces the risk for pressure ulcers and DVTs and also helps mobilize respiratory secretions.
I think you're right, Sarah.
My turn to ask you a question, Angelique.
Okay.
Mr. Gold's brother visits and he asks about the reason for the NG tube. Which of the following response is best? A. The tube allows us to keep track of the amount of fluid in the body. B. The tube removes bacteria from the body. C. The tube allows us to administer feedings. Or D. The tube prevents the stomach from filling up with fluid and air.
That's a hard one, Sarah. I think the answer is the tube prevents the stomach from filling up with fluid and air. And my rationale for that is until peristalsis returns, the gas and fluid that accumulates in the stomach can cause vomiting. Okay, one more. When assessing Mr. Gold's NG tube, you note that it's connected to continuous high suction. Which of the following actions should you take? Clamp the tube for 30 minutes and let it reconnect to continuous high suction. Call the physician to remove the tube. Irrigate the tube with 30 milliliters of normal saline and then clamp it for 30 minutes. Or change the suction to low intermittent suction.
Well, Angelique, the answer is change the suction to low intermittent suction.
That's correct.
Because high suction can cause trauma to the gastric mucosa.
Okay, thank you for listening and good luck on the test.
Bye.
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 Watch our bloopers.
Bloopers. By the way, we wanted to give demonstration of a spirometer. And this is how you do the deep breathing, which allows for
Expansion of the lungs.
indicate the return of a bowel cancer or metastasis. Mr. Gold's cancer was limited to the tumor. Mr. Gold's cancer was limited to the tumor and the mucosal layer of his sigmoid colon. There was no evidence of lymph node involvement or metastasis. I can't do it.
Okay.